You may have noticed that today's episode is a bit longer than usual, and it's a brand new format. So welcome back to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. I'm your host, Colleen Sloan. I'm a PA, dietitian, and today I've got two experts joining me, Michelle, a registered dietitian, and Josh, a PA and clinical lipid specialist. We're unpacking heart health from both sides of the exam room, nutrition and medicine. Now, unless you're lucky enough to be both an RD and a PA, it can sometimes feel like we're giving advice in a silo. Here's a prescription for a statin, or here's a list of foods to lower your blood pressure. But what I wanted to do in this episode is bring these two worlds together to highlight how each expert thinks, what they prioritize, and how they talk with their patients. Now, Michelle and Josh don't always agree, especially when it comes to low-carb diets, but they do share one core belief, that the best care meets patients where they are and helps them get to where they want to be. So in this episode, we start by exploring when and why cardiovascular disease prevention matters. We dive into some advanced lipid testing, and then we tackle a tricky case, a patient with hyperlipidemia, insulin resistance, who is also going through menopause. And I promise you will definitely want to stick around until the end, minute 38:50 to be exact, because that's when things get a little spicy as we debate low-carb diets. Are they harmful or helpful? Now, as you know, I am not clickbaity or debatey. Is that even a word? But hearing both sides of this argument was really interesting. So after you hear the discussion, can you shoot me a DM on Instagram at Exam Room Nutrition and let me know which camp you're in and why? Do you agree with carbohydrate restriction, or do you think there are other ways to help insulin-resistant patients? I'd love to hear your thoughts. And if you're not already on my email list, I send out a free weekly newsletter with nutrition news, stories from patients in my exam room, and practical scripts that you can use with your patients. It's totally free, and you can sign up at examroomnutrition.com/sign up. The link will be down in the show notes. All right, well, let's get to it. You might need to split this up on your commute or your walk today, but let's unpack heart health and see how PAs and RDs think differently, yet work together. Because isn't this how the healthcare team should work anyways? Michelle and Josh, I am so excited to have this fantastic duo on the podcast today. I can't wait to have this really dynamic conversation to just showcase teamwork and how we can work together as dietitians and PAs. And so I want to start with a quick round of introductions, even though both of you have been on my podcast before. Let's tell my listeners who you are. So Michelle, could you please share what you do and what your role is when it comes to heart health patients?
Yeah, well, Colleen, thank you so much for having me. I'm excited to be here with Josh today. I am a registered dietitian who specializes in cardiovascular disease. My mission with my clients and with just my audience is for people to understand the whole picture of heart disease and not just be chasing one lab, but understanding that it's complicated, it's nuanced. There's a lot to do in cardiovascular disease. And in order for us to reduce the risk, we have to be looking at the whole picture. So I'm excited to be here.
And Josh, you are a PA and a clinical lipid specialist. What is your role in managing some of these same patients?
Yeah, so I've seen thousands of patients, and I have been very blessed to see people in various capacities. I also have my doctorate in physical therapy and a PhD studying cholesterol disturbances and Alzheimer's. Basically, I have very few useful skills except going to school and taking tests. But regardless of if it's a random person in an airport or one of my patients or one of the clinicians that I'm teaching lipid biochemistry to, I want to capitalize on the fact that no one wants to have heart attacks, strokes, and dementia. And I think equipping people with a relatable framework to not have heart attacks, strokes, and dementia is of paramount importance. And that's why I write books about the topic. And that's why I'm going to talk about my home security system and lipid neighborhood framework, because I want you, whoever you are, to not have heart attacks, strokes, and dementia, and to be able to add some life to your years in the process.
I'm so excited to pick both of your brains because as I've shared with you before, like cardiology is not my wheelhouse. And I love learning from both of you with your unique background and education. So before we get into the specifics about labs and treatment, I really want to start with prevention because we know that 80 to 90% of CVD is preventable. So Michelle, what are some of the risk factors for cardiovascular disease that you talk about with your patients?
Yeah. So first off, I always like to say, because you never know where people are in their journey, it's never too late. There's primary prevention, there's secondary prevention. And a lot of people say, I get this all the time in my Instagram. I'm waiting for a stent. I've already had cardiac bypass. It's too late. I'm 74. It's too late. It's too late. And it's like, it's never too late. Wherever you are, prevent complications of heart disease, we need to start with where you are. So I never like to say only prevention is only before we are diagnosed. It's actually at any stage of which diagnosis occurs or an event has previously occurred. With that, we have to be looking at everything. So we have to look at atherogenic LDL cholesterol, which I think we'll dive into in a little bit. But we also have to be looking at insulin resistance. We have to be looking at inflammation and inflammatory markers. The number one thing I always tell people is before you even go to the doctor, because that might take a couple of months to get an appointment, buy a blood pressure cuff and take your blood pressure. It's the number one thing I want you to do for your heart. We also need to be looking at nutrient adequacy. I think we're in this kind of realm when we talk about diet is, I don't eat this, I don't eat that. I'm part of a carnivore team. I'm keto, I'm this, I'm that. But people then lose the real importance of, are you getting the nutrients your body needs to thrive, which helps your heart beat regularly, which helps your body function properly? So we need to be looking at all aspects. And if you only look at lipids, or you only look at insulin resistance, or you only look at inflammation, many times you chase a number and then the other numbers go up. And so then we have what I call havoc in the blood vessel. So what we're really looking at is optimizing cardiometabolic health that helps to improve blood flow, helps with the plumbing, the pump, and the electrical system.
Oh, you explained that so nicely. Okay, Josh, she mentioned something and then I think is brilliant that a lot of patients don't really consider, and that prevention can start at any time. But when do you think clinicians should start educating patients about prevention, or even when should they, look at a patient and have some red flags?
Yeah, yesterday is when they should have started with the prevention conversation. And Michelle said some wonderful things there. And really what we want to do is shift the paradigm in Western medicine and throughout the world from one of reactionary to preventive. And Michelle brought up some good points as far as what is primary prevention, what is secondary prevention. Well, historically it's been, well, we'll wait around for you to have a heart attack or a stroke and then we'll do something. No, we want to identify disease in its embryonic state and we want to get ahead of the game. And we have imaging modalities along with our blood-based biomarkers to make better sense of the whole picture now and intervene accordingly. And so across the lifespan, though, no matter what your lipid neighborhood is looking like, we want you to not be insulin resistant. We want you to have good blood pressure. Life is better not inflamed rather than more inflamed. And then if you're doing drugs, you should probably consider stopping. Those are the 4 pillars of my home security system. Regardless, across the lifespan, no matter what age you are, we want to be focusing on those things. And one of my mantras is control your insulin, control your life. And then your lipid neighborhood, well, every ApoB containing lipoprotein, the vast majority of those under normal physiologic circumstances being LDL particles, are potentially criminals that can infiltrate your arterial abode. And, the Lp(a) particles, those are the felons if you pick the wrong parents there. So it's good for us to know your numbers from a very early age. And that's why it's recommended from age 9 to 11 to have this universal lipid screen, because not knowing doesn't make things go away. And if we know things, hey, this was not something that we're making people nervous about. This is making you actually take ownership of your health, and we can help you with that. And oftentimes, the number one prescription we can give people is hope. And the number one thing that we can equip them with is knowledge. Knowledge is power. But oftentimes, laughter is the best medicine, too. And so if you have somebody in your corner who cares about you and can, give you a little love and a little laughter along the way, it makes all the difference in the world.
So I think a lot of times people think, well, I'm an athlete. I'm not overweight. I work out heart disease won't happen to me. And this is why it's so important that we must be checking your labs to know what's going on the inside. I can't tell you how many times people are like, yeah, I'm an athlete, I'm not going to the doctor, and they have a massive heart attack because they had no idea what was forming. We have silent signs. And the only way to be proactive is to test and not guess so that we can take more ownership. I have so many people who also say, my dad died of a heart attack at 54, and now I'm approaching 54, so I want to take ownership now. I'm like, wait, why are we waiting until this time? A lot of times people get scared. They get a high LP little a and they're scared. Oh my God, I'm going to have a heart attack. They're really nervous. And like you said, Josh, like take that fear of, oh, I have a family history, turn it to empowerment. I know I can do something about this if I take action. And that means we need to move those targets a lot lower to help make sure that the environment is not going to accelerate that plaque given your genetic history. And that needs to happen from taking a proactive stance. And that entails everyone to take ownership of their health.
100%. And it even applies to neurodegenerative disease too, like with the ApoE genotype. That's the number one genetic risk factor for Alzheimer's disease.
Yeah. And brain health and heart health go hand in hand. I think a lot of times, like you mentioned, like it's siloed. But no, when we take care of your heart, we take care of every organ of your body.
So Michelle, I want to move into nutrition a little bit. And obviously this is just such a big topic, but I would love to pick your brain. And if you could kind of name a few of your top foods that you think patients should prioritize to keep their cardiovascular system healthy.
I love that. So first off, I always like to, when I'm looking at someone's diet, to really ask the question of what do you avoid? Whether it's you hate it, you're allergic, you think it's bad for you, what are you avoiding? So a lot of times now it's like, oh no, gluten's terrible, dairy is terrible, everything's terrible. So no one's eating anything except maybe one particular food group. So my thing is like, okay, if you're avoiding gluten or you're avoiding dairy, what are the nutrients you're going to get from other foods to help make sure you're not nutrient deficient in that? So that's kind of where I start. But again, diversity is important. Making sure you're getting enough lean protein, making sure that you're getting enough complex carbs of vegetables. And if your plate only has green in it, that's wonderful for vitamin K and folate, but perhaps you need some orange for beta carotene. Maybe you need some red for lycopene. Maybe we need to expand the differences so that you're supporting nitric oxide production. We need to assess kind of what's missing and how do we enhance. And then we also need healthy fats in the diet. So I would kind of look and say, you really need a lot of different foods. Do we want to limit some? Sure. But I would focus in on what we need to add into the diet and for you to maintain a healthy body weight, for you to get the nutrients you need to combat inflammation, to support your workouts. It's really focused on those aspects. I think another big part for a heart health diet is calcium rich foods. A lot of times people think, oh, I have a high calcium score, I can't eat calcium. But what happens when you don't eat calcium, your parathyroid hormone signals to your bones, let's get some calcium from your bones because you need it for your heart to beat regularly. And that, if the environment is conducive, can cause a potential for calcium to deposit into the arteries. So it's important that we have enough calcium to strengthen the bones and to make sure that it's not leaching into the vascular system. So I can't really give you the top 5 without saying like, well, what are you eating? What are you avoiding? What does this all look like? I wish it could be like, hey, everyone just eat this and you'll be good. But we don't work like that, especially because food is complex. We have cultural preferences, we have food likes and dislikes, we have allergies, we have food intolerances. And so it needs to be personalized to you because a heart healthy diet needs to last long term. It needs to be consistent and it needs to achieve cardiometabolic health that's going to last forever and not just be a quick fix.
This is why I love asking these types of questions because these are the questions we're getting asked by our patients in clinic. And I love that you didn't say 5 foods, blueberries and fish and blah, 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 because that's kind of what we are expecting. That's kind of what our patients are expecting. But I really love that hopefully in medicine, we are moving towards personalized nutrition. And that's really what we mean. Exactly how Michelle answered it. Yes, we could give them a handout of heart healthy foods. There's plenty of resources out there, but you really have to get to know your patient in order to tailor, their diet to optimize their health overall. So Josh, when you talk diet with patients, are there certain things that you prioritize from like a PA lipid specialist mindset?
Well, yeah, I mean, we know now that if you just take out food dyes, it makes whatever the food is automatically healthy. And so that's what, no, I'm just kidding. So really my deal for diet is there are multiple dietary patterns that can work to optimize both your metabolic health and your lipid neighborhood. The standard American diet is just not one of them. And so my little catchphrase is prioritize protein, eat real food. And then people are like, oh, come on, I wanted a specific thing. I'm like, well, that works, you know? And so that really is the deal. And intuitively, when you are driving through Krispy Kreme, you're not thinking, yes, I am really making a consciously good health choice today. No, you intuitively know that that's probably not the best choice that you could be making. And if you're doing that every day, day in and day out, and then, washing it down with a Coke, that's probably not going to be great for you. And so, hey, if you stick to the prioritize protein, eat real food, that probably will take care of whatever you're doing. And then, if you want to endorse something that's more Mediterranean, okay. If you want to endorse, something that has some other semantic label on it, fine. But dietary things get really tribal and they honestly become, I think, more religious than actually the purpose of a diet, which is fueling the machine so that you can go crush it at life.
So I think a lot of times I hear this so often where it's like, oh, just go on any diet as long as it's like, you have protein and whole foods and blah, blah, blah. And like the biggest thing is that when you label a diet as Mediterranean, vegan, vegetarian, every single person, you take a group of 10 people, they will have different interpretations of what that means. And so what I love about research is there is a really cool part of research called nutribalomics. And nutribalomics looks at when you eat certain foods, what byproduct your gut creates from it. And what does that happen with your lipids and with your insulin resistance and with everything biologically? And when we look at those research, we see such improvements in cardiovascular disease. And so that's super cool. And it's not biased with a food recall or things that are not necessarily specific or being able to look at. That's one. But another really cool study that I have to bring up on this episode, because I'd be dismissive if I didn't, is the DISCO-CT trial. I don't know if you know about the DISCO-CT trial, but it was looking at individuals who have plaque in their arteries and especially soft plaque. And they found that when a doctor prescribed medical nutrition therapy and when a doctor prescribed medical therapy, so they were put on the right amounts of medication to lower their values, when it was paired with diet, specifically the DASH diet that a dietitian was making sure was implemented the way it should be implemented, we saw a much bigger regression in soft plaque. And so we know that diet has a huge role, and it's not just eating whatever, it's really focused on, are you getting enough magnesium and potassium and calcium and lean protein and whole grains and all the aspects of these diets that are shown to improve heart health. So I think we do a disservice when we look at food recalls and say, oh, diet doesn't have an effect or it only lowers LDL by 5%. Well, no, it's not specific. It needs to be targeted, which is why we have to collaborate to make sure that when medication is necessary and nutrition is paired with that. It's not one or the other a lot of times. And I think we sometimes look at it again in that silo mindset.
Whatever diet you're endorsing, if you are showing signs of insulin resistance, I think we need to reevaluate what you're doing dietarily. And the first thing is, if you're showing signs of insulin resistance, are you exercising? Well, if not, you should start. And, the quickest way to abrogate insulin resistance is start moving your muscles, because we know from Jerry Schulman's elegant work at Yale that insulin resistance starts with skeletal muscles. So move the muscles, and then you're going to quickly ameliorate that. Now, if you are exercising or you're not in the position to or whatever, and you're showing signs of insulin resistance, well, hey, let's talk about what you're doing dietarily, and probably we can modify some things to restore insulin sensitivity.
I want to move into the meat of our conversation, and that's talking about labs, because like we have talked about, we've got to have a baseline. We need to get labs. We need to do testing to really know how we need to tailor a patient's diet. And so most clinicians are very familiar with a basic lipid panel, but I want to go beyond that. And let's talk about some advanced testing or additional tests that clinicians can order. And I first want to start with you, Michelle, because I hear from dietitians all the time that are like, oh, I wish the doctor would order XYZ test because it would give me as a dietitian so much more information so I can better guide my patient. And so can you give us an overview of which labs you wish clinicians ordered more often that would give you some key information when working with heart patients?
Yeah. So, I mean, there's so many different labs that would be helpful to assess things a little bit further. If I would have to pick maybe top three, I would say one is inflammation. So I like to look at HSCRP, and it surprises me so much that many doctors will push back with HSCRP because we have the data. We have data when traditional cardiovascular risk factors are in normal range, cholesterol, blood pressure, but HSCRP is high, especially in women. It increases the risk of cardiovascular disease tremendously. So we should be testing it. That's one. The second one that I like to look at is more of a advanced lipid panel. And I say this because I think a lot of social media influencers are kind of looking at just saying like, oh, the lipid panel doesn't matter. But we get more data when we look at LDL particle size, when we look at ApoB levels, when we look at LP little a, both from a risk standpoint, but also to the granularity of actually how much of these atherogenic LDL cholesterol is there. There is a population that, has discordance between their LDL and their ApoB. And we want to just test it to make sure we're doing a good, thorough evaluation of the atherogenicity. The third thing I would like to test is LPIR, which is your insulin resistance, because you can have normal blood sugar levels for decades and you can be insulin resistant. And we can test it. So why aren't we? So those would be my top three.
Michelle, can I ask you, who would you consider those for? Would those be someone who is at risk? Maybe they have obesity and diabetes already, or would those just be general screening that you think every adult should get?
Every adult. I think that we have this thought that only heart disease happens and only insulin resistance happens in someone who's obese. And that's not true. I see people who are underweight, normal weight, and obese as well. And heart disease does not discriminate based on body size.
Okay, Josh, I'm sure you have some thoughts and then any additional tests you would want to order.
Yeah.
And then I want to dig into those kind of in more detail, a few of those to kind of unpack, well, then what do we do with the numbers that we get? But
Yeah.
Josh, what else would you add?
So the LPIR is great. And it's actually a better predictor of who goes on to develop type 2 diabetes in the Women's Health Study in MESA. And it's part of a composite of your advanced lipid subfractionations. And I am a big fan of understanding the individual utility of each test that you're getting, but it can get really muddled. I mean, Michelle has a lot of background in that. I have a lot of background in it, and I explained how to interpret all these things as far as, you got your large VLDL particles and your small HDL particles and your small dense LDL particles. And it can be very overwhelming for somebody who hears us having so much fun on a podcast talking about these things. They go order this and they're like, crap, what do I do with this? And so I think insulin resistance, right? Identifying insulin resistance early is of paramount importance, because insulin resistance and impaired fasting glucose and prediabetes and diabetes, well, they're all in the same continuum. And so I'm a big fan of the HOMA-IR, getting a fasting insulin along with your fasting glucose. You can multiply those two, divide by 405, and you can get your HOMA-IR. If you're comfortable with C-peptide is actually secreted when insulin is secreted simultaneously. And if you have a good handle on interpreting C-peptide, that can actually be of potentially even greater utility than just a fasting insulin, but there are very few people that probably are comfortable with that. But that's another way to look at it. But regardless, we want to identify insulin resistance early. And using those advanced lipid panels that include the LPIR is one of the ways that you can even identify insulin resistance in its infancy. And so my wife was a good example of this. And so, she's obviously beautiful, gorgeous, just a goddess descending from on high, but she wasn't really feeling that well. She wasn't exercising at the time. And her LDL cholesterol was like 80, totally normal. But then her LDL particle count was 1,300. So it was discordantly high. And you can get an ApoB to measure discordance as well. But it was discordantly high. And she wasn't exercising. After 3 months of just exercising 2 to 3 times a week, combination resistance aerobic exercise, her LDL cholesterol didn't budge, but her particles went from 1,300 to 994. And you can see the same sort of things with dietary interventions too, when you get particle metrics, because ultimately it's not about the mass of cholesterol that's delivered on lipoproteins. It's about particles. Particles dictate risk. Particles dictate risk when it comes to our ApoB containing lipoproteins like VLDL, IDL, and LDL particles, but also when it comes to LP little a particles. Each particle is potentially a criminal. Each LP little a particle is potentially a felon. So it's good to know your particle metrics. And additionally, inflammatory markers, right? HSCRP it's an independent risk factor, as Michelle stated. However, I think it's important to know why your HSCRP may be elevated. And so, maybe you have a systemic autoimmune disease, like rheumatoid arthritis or psoriasis or something like that. And those people, unfortunately, do have an increased risk of cardiovascular events because of that systemic inflammation. However, most hsCRP elevations are due to angry adipose. It's usually due to visceral adiposity. And that's how most hsCRP is elevated. And that's why we see such tremendous reductions in hsCRP with our incretin-based therapeutics, things like semaglutide, things like tirzepatide. And so there's all these sorts of markers. I think identifying insulin resistance in its embryonic state is of paramount importance. And I also think that the inflammation goes right along with that.
I want to linger here on labs, but I actually want to take it into like the clinic, like what we would be seeing in clinic to give our listeners some actionable tips. So I'm going to make a fake patient. We've got somebody with elevated LDL. So they've got hyperlipidemia, but they also have, and then I'm going to give a few different examples of some things. So right now we're going to talk about this patient with elevated LDL, but also elevated CRP, and is insulin resistant. So maybe they've got an A1C of 7.8. So Josh, I want to bounce this to you. How do you, for this patient, how would you think about treatment? And I'd like to pick your brain on more of the medical side, because then I want to hear from Michelle about the dietary management. So we've got elevated LDL, elevated CRP, and insulin resistance already. What are you thinking as a PA?
Holy smokes. Okay, this sounds like a lot of the patients I have seen over the years. And so A1C 7.8, let's say this person's 50 years old. How about that? And so now guidelines would say, hey, the person's got, diabetes already, and just go straight to, a statin plus all the other things you're doing for their diabetes. For me, one of my catchphrases is got plaque, get a CAC. What's a CAC? Coronary artery calcium score. It's the colonoscopy of the heart without the nasty pregame show. And it shows if you have calcified plaque in your coronaries or if you don't, which is a late finding in the disease process. Now, a lot of times people with diabetes and hypertension, Lp(a), these other risk factors, they might actually have soft plaque as well. But the calcium score definitely gives me some good insight into how aggressive we need to be from a lipid neighborhood perspective, even in people with diabetes. So I'm going to still get that. Now, this person's home security system is really, really not good, right? I mean, the person's already got diabetes. And so now, can we reverse the diabetes? Probably. And if we get a C-peptide, we can know if that person is still secreting their own insulin. And oftentimes, and this is the case with most of my patients, is they would come in, and the issue with them is that they're still secreting insulin. Their fasting insulin levels are usually quite high, but all your tissues are desensitized to the insulin signal. They're not listening. And so what we have to do is restore insulin sensitivity. And what's cool, and when people are that far along, I would like to, rather than wait around to reverse your diabetes, which is it's possible. It's totally reversible, type 2 diabetes, if you still make your own insulin. And I would usually reach for an incretin-based therapy right off the bat, in order to help catalyze the right dietary approach that can shift you to prioritize protein, eat real food, especially early on. Some degree of carbohydrate restriction is super helpful for people with type 2 diabetes. And then, hey, guess what? Pretty quickly, we could get their A1C from 7.8, you said, down to 5.5. I mean, this would happen usually in 3 to 6 months if we really got on board, but it would require frequent follow-up too. And ideally, I'd have my dietitian working with them too, to keep on having accountability for whatever we are doing there. And it really takes a team, but I would rather than wait around and do the typical, let's use some metformin first. And, then people hate you because they're having diarrhea all day, and I mean, you can still use metformin. It's a fine tool. But rather than just, wait around and just up titrate slowly, I like to go, hey, let's nip this in the bud right now. Let's get after it. And then, see where we land from there. And then, when I get the CAC, that's going to give me some insight on how aggressive I need to be with the lipid lowering therapy. There's some nuances to what's going on in the lipid neighborhood there, but that, there's a lot going on. When someone is that far along in the process and they have crossed that threshold, and I mean, that's a ticking time bomb. And so it's going to be potentially an all hands on deck situation there.
Well, thankfully, you work in a multidisciplinary office, and they have a beautiful dietitian on staff full time, which is incredible. And so now it's time for the dietitian to come in the room and talk to the patient. So Michelle, with this patient, what are you thinking about? What would you like to prioritize? And what are things that we should consider when we talk about nutrition for them?
Yeah. So first, I have a lot of questions to this patient, but we're going to go on Josh's. It's a 50-year-old. I'm going to make her a female. Okay. So now I'm asking questions of, the menopausal transition, because a lot of times people are not aware of these shifts. So I want to look at her trends. Is this just happening? Most people are not necessarily alarmed of these things until it becomes at this stage. So I want to hear from her. What's going on with her? What are changes that are happening in her body? And what is she doing otherwise? This happens very often. And I'll give you a little bit dialogue between what normally would happen. Okay. So I'm talking to this woman and I say, tell me a little bit about your journey. Maybe she's a little overweight. And she's like, you know what? In the last couple of years since menopause, I've been getting a lot of weight around my abdominal region. That makes sense with the story, right? So she has inflammation. Perhaps it's from the visceral adipose tissue. That's A. Then secondly, I'm like, ooh, going through menopause, she's going to be more insulin resistant. Her cells are not as insulin sensitive. Okay, I'm putting things together. She goes, yeah, and I want to lose this weight. I don't like this abdominal weight. So I've been going on a very low calorie diet and I've been going low carb. So then I want to explain to her what's going on in her body. Explain to her how during the menopausal shift, what happens and how our food needs to shift alongside that. So for one thing, the LDL receptor activity declines in menopause. So yeah, it makes sense your LDLs are going up. Now we need to eat differently. We need to make sure we're not plugging up her LDL receptors further. How much saturated fat is she consuming? What does that look like for her body size that would help to make her LDL receptors more active? I want to look into kind of the inflammatory component. Yes, visceral adipose tissue is one component, but is she having gut issues? Is she having acid reflux? Is she constipated? That can also contribute to inflammation and weight gain and higher LDL as well. So I'm really listening to her and seeing where she is. Most people who come to see me will say, my doctor wants me to go on the GLP-1s. They want me to go on a statin. They want me to go on all these 5 different things. And like, I just learned about this. Like, I'm not really for medication. And I then explain to them, depending on their situation, in collaboration with their doctor, of what would make more sense. Which one should we prioritize? What are we doing to monitor and adjusting as needed? We have to be listening to our patient, because if I tell you how many people say, my doctor prescribed a statin, but I haven't taken it. And you know what I'm going to do? I'm going to take it the day before I see him just to appease my doctor. We have to be listening to our patients. We can't just throw a million medications that they're not going to take. So at the end of the day, yes, we have guideline therapy of what we need to do, right? But how we do it has to be with what the patient is actually going to implement. And so a lot of that takes a lot of the why and the explanation. And that's important. I'm not against medication. I've helped many people actually consider a statin because they have familial hypercholesterolemia. Their LDL is 190. They have plaque in their arteries. It's risky. They're like, thank you for explaining why this is important. But I think we really need to be listening and explaining these things, or else we're going to have non-adherence. And so my biggest takeaway from all of that I would want to share with your audience is listen to your patient, see where they are so you can really help them.
Your vignette, you gave me a super sick patient, so I hit the panic button, but really, you meet people with that. And the menopausal transition is cruel for many reasons. Anybody who says it's fair is wrong. And even LP(a) can go up quite dramatically in the menopausal transition as well, just because estrogen binds to the promoter region of the LPA gene on chromosome 6 and suppresses your true basal production rate. And so then it can go up, and that's not fair either. I think that too, to your point, I mean, for someone with a calcium score of 0, right, the number needed to treat for a statin ranges from 3,571 to infinity. And so, okay, if you have any plaque in your coronaries, that you can identify, I would prefer to stabilize that plaque. And we have ways of doing that. And then can we even regress that plaque if we've identified that? We can. And so, using our whole battery of tests and biomarkers is good, but ultimately too, meeting that patient where they're at, and then talking to them. And this is, why my appointments would take an hour and a half. You can't just go in there and be like, I have this credential or this or this or this. I'm a doctor. Do this. That's not going to work. You gotta actually make sure that person understands the process. And that's why I use a lot of metaphors and have a framework that we can both relate to, and then we can get there together.
Sorry, one other thing. I think it's important to mention the calcium score is great, but especially in women, it doesn't necessarily tell us the whole picture. And I think a lot of people think, my calcium score is 0, I'm in the clear. My ApoB can stay high. My LDL can stay high because I have no hardened plaque. That's the last stage of the plaque formation process. And many women have it in the small arteries that don't show up in the coronaries. Many women have a calcium score I've seen of 0, but they have carotid plaque that's soft that we can see. So we have to realize that just because you have a 0 doesn't mean you're free. And so I always like to say it's a tool, but it doesn't mean that we can ignore LDL right now. It just means that we have to be understanding that your body is not at the end stage of plaque, but it doesn't rule out that soft plaque either.
Yeah, and we have other modalities, right? We have CT angiography, which will show you the soft plaque and the degree of stenosis. 44% of the time, plaque starts in the iliofemoral distribution from the PISA study. And if you have a skilled sonographer who does carotid IMT with plaque assessment, I mean, yeah, you can identify that too. And so I think regardless of the imaging modality, CAC's a great screen, right? It's like the colonoscopy of the heart, right? But is it perfect? No, it's a good tool. It's a real good one. But also in a young person, not so good, in the under 40 crowd, and so, but if you have a score of above 0 and you're under 40, oh, that's real powerful. We're really need to get after it. So we have to be able to interpret. There's a lot to it, you can't just say, oh, I'm good here with this one test or this one imaging modality. You have to take it as a whole. There's a lot to know, and this is why it's tough. And all you get taught is LDL bad, HDL good, everybody take a statin. Well, there's a lot more to it than that. Look at this talk we've had. I mean, there's a lot of nuance. And so that's why, we have to hopefully get out there and get the message out and get people thinking about this. But I think it's worth knowing. It's worth pursuing just because this is the number one killer of people across the globe.
Okay, I want to linger here. And I think you two may disagree on treatment for this specific person, but I actually want to talk about it because I think it's an important disagreement that people are going to want to know. Because I know we talked about like how important it is to listen to your patient, look at all of the tools that we have, but they still want to know, like, what do I eat? My listeners still want to know, like, well, what do I tell my patient? Like, what diet, quote, should they follow? Josh had mentioned, and I'll allow you to speak a little bit more to this. Josh had mentioned a version of a low carbohydrate diet. I want to sit here on that because I think this is important because I know a lot of clinicians will be like, oh, just follow low carb. If you're, have diabetes, low carbohydrate. And so Michelle, I know there's so much nuance, but I want to pick your brain a little bit. How would you address the diet for a patient who is, elevated LDL, has diabetes? What are we talking about here? And do you agree with following a low carbohydrate diet?
Great question. So I know I keep saying this and I'm a broken record, but I'm going to say it again. It's a nutrient adequate diet. I can label it as Mediterranean. I can label it as the DASH diet. I can label it as the DASH Mediterranean, however you want. It may get muddled in interpretation. But what I mean by this is if you actually look at the research of how do we lower HSCRP, it's by nutrient adequacy. And it's not just by eating more fruits and vegetables. It's about getting enough B12. It's about getting enough folate. It's about getting enough of selenium and magnesium. And it's the adequate, not too much and not too little. A lot of those foods are in whole grains that have carbs in it. A lot of those foods are in beans and legumes. That's a carb. There's foods like yogurt. That's a carb. There are a lot of carbs. I'm not telling someone to go eat candy and sugar and bunch of refined sugar. We're aligned on that. But to eliminate carbohydrates makes many people go on a very high saturated fat diet, which will increase ApoB, it will increase LPIR, it will increase LDL. And I will be remiss without showing the study that recently came out that's been so misinterpreted that drives me crazy. And that's the keto trial. Right. So the keto trial came out. It looked at people who were metabolically healthy. They exercised. They didn't have high blood pressure. They didn't have insulin resistance. They didn't have anything except for high LDL and ApoB. And they had the fastest soft plaque progression we've ever seen in 1 year in a study. And now you might say, oh, well, the people wrote, well, plaque begets plaque. Anyone who understands how plaque is formed in the arteries knows that just because you have plaque doesn't mean more plaque forms within that quickly in 1 year. That high ApoB and LDL from a ketogenic, high saturated fat diet was causing that dangerous plaque to form. So it's important that when we're looking at nutrition adequacy, we're not just eating only carbs. That's not what I'm saying. We're eating a diet that has carbs in the right amount, in the right form, paired alongside protein, your whole grains, and your healthy fat to give you all of the nutrients your body needs to thrive, fuel, satiate, and allow for the optimal utilization of insulin so we make ourselves more insulin sensitive. You getting rid of carbs, sure, that can lower your blood sugars temporarily, but it's a Band-Aid. You're taking away the carb, you're taking away what's causing the blood sugar rise, and that long term is not going to be helpful. A, and B, you're going to have more saturated fat, which it's like the gum in our LDL receptors. And we can't just be looking for one target. You can't just address insulin resistance without addressing atherogenic LDL cholesterol and inflammation. And so we have to look at the whole picture.
Yeah, context matters, right? Colleen gave us a nasty vignette because the person has, an A1C of 7.8, right? And oftentimes, it depends, right? And this is why we need all our cadre of biomarkers. We need to meet people where they're at and all these other things. And so, because a lot of times people with type 2 diabetes, they go on a low carb diet, and really, I think biochemically it makes sense, especially in the short term, okay, right at first, because you're still making a lot of insulin. And the most potent way that your body secretes insulin is in response to dietary carbohydrates. So if you restrict carbohydrates to some degree, people get better. And then you're able to restore insulin sensitivity, and then you might have some more room to work with down the line. And so, but really, a lot of times people who have diabetes, they go on some sort of low carb diet, and then their lipid panel actually gets better, and their ApoB actually drops, and so it depends. It depends on the person. And so it's good to recheck. The keto CTA trial is very, very interesting. It's a ongoing topic of much hullabaloo. And, the greatest predictor of plaque progression was people who already had, positive calcium scores. And it was quite dramatic in the initial publication. Subsequent data sets are interesting. From my takeaway from keto CTA, which that story is not quite finished, is, hey, if you've been broken into, do you want to keep living in the same rough lipid neighborhood where there's so many lipid criminals that are continuing to break in? I would not, and I think that a conversation needs to be had about, the purpose of that dietary pattern in those individuals, and also some other interesting ways to possibly get living in a safer lipid neighborhood, especially if you've been broken into. My friend and I just submitted a publication, an article to the Journal of Clinical Lipidology with our mechanistic speculations on why certain people who tend to be of a lower BMI have this stratospheric rise when they adopt a low carb ketogenic diet. It's really, really fascinating. Super deep dive. I'd probably lose all my friends if I went into the details right now. So I'm not going to do that.
I want to linger on the nuance because both of you have used the terminology low carbohydrate diet. And I think clinicians still do this to their patients, and they say, I want you to follow a low carbohydrate diet. Well, what on earth does that mean? So Josh, I want to ask you, if you were to say a low carbohydrate diet, do you have a grams in mind? Are you telling patients they should be on 130 grams per day, 150, or not really? You're just kind of using that as a catch-all phrase.
Yeah. And so what I would say is like, hey, let's sit down here and I'm going to go through a menu and we're going to talk about what you eat and what you like. And then we're going to talk about ways that we can maybe swap out something here that isn't so good for something that's a little bit better. And so I wouldn't even have them focus on a number. It depends. Like if they're an engineer and they're like, I would need a number. And I'd be like, okay, well, I'll give you a number, 50, sure. And they would do it. But most of the time I would just go through qualitatively and say, okay, what are we eating here? Oh, you're eating raisins. And also, continuous glucose monitors are great ways to show people, oh, yeah, that was a bad idea. They eat a couple of raisins and their glucose spikes up to 240. Maybe don't do that, And so anyway, so that's a great tool that we have too to help you understand what your body's doing with various things. And to Michelle's point too, there are certain things that, that might be a healthy food, but it's irritating your gut. And so your blood sugar spikes because it's stressed. And you could only determine that if you're wearing a CGM. So CGMs are pretty cool tools. But anyway, I would go through and just say, hey, what are you eating here? What do you like here? Oh, you're eating rice. You know what? You could swap out some rice cauliflower here. Oh, that might be good. Still tastes good, So that was my approach. But then other people might want, and can it work to have specific macros? Absolutely. Can it work to do other sorts of strategies? Sure. That was my approach. But once again, everybody's different. Meet people where they're at.
Michelle, what's your take on low carb? What's your definition? Do you give patients grams per meal or anything like that?
Good question. So I don't give grams per meal, but we know that we need at least 130 grams of glucose, carbohydrates for our brain to optimally function. So I don't like going below that. When we induce ketosis, it's really like for 15 to 30 grams. So when we're talking about the keto diet, I'm using that definition for low carbohydrate. I think a lot of times when we focus in so much on like specifics in terms of like, oh, if you say the only fruit you can have is berries, for example, you're missing out on so many subclasses of polyphenols that you can't get from not including other fruit in your diet. So I'm more about nutrient adequacy, but also pairing, right? So your example, I love CGM monitors if the person is with a dietitian, because I can't tell you how many times people say, I can't eat any carbohydrates because I took a CGM. I'm like, well, you don't know how to read your CGM. So let's talk about it. Let me explain to you what's going on. So that's one. But if you like raisins and that's something you're eating because of the polyphenols, because of all of the resveratrol and all the things that may be found in raisins, and it's spiking your blood sugar, it's likely because of a couple of things. One is the portion, and two is what are you eating it with? No one said to eat carbohydrates by themselves. You can pair it with nuts and seeds, yogurt to buffer the blood sugar rise. And when people learn those skills, they're like, wow, my blood sugar didn't even go up at all. I'm like, you just need to know how to pair your food. The nuance matters. I'm not saying to go eat a whole bowl of fruit. No one like that it has sugar in it. It will spike your blood sugar. What are you pairing it with? That's what matters. And those nuances are important. And so to tell someone to just eliminate all of the fruit because it has sugar in it, do you know how many polyphenols, vitamin C, things that aren't found in other foods are in that category? And so I don't like to say only eat berries because berries are great. Are they a rich source of potassium? No, they're not. And so where are you getting that from in other sources? And so it's important that we are really looking at all of that.
I think the common thread with any of these things is if you have accountability and you have frequent follow-up and you have people who are in your corner who you trust, who care about you, then you're going to do well, And once again, Colleen, man, you should have chosen somebody who, just is feeling a little tired, who is entering the menopausal transition with an A1C of 5.5. I mean, that would have been a lot easier conversation to have.
That example is my patient. I like your example. That's a perfect patient.
I got to challenge you guys. Well, we are nearing the top of the hour, and literally I've barely scratched the surface to all the questions that I wanted to ask you guys. So for those of you who want to learn more or hear more about them, you can listen to previous episodes where they were both on my podcast separately. Michelle was on my podcast, honestly, when I first started. She's episode 38, titled Love Your Heart, Nutrition Insights That Save Lives. I will link down to that below. And if you want to hear from Josh, we talk more about HDL, LDL, and a little unpacking of the diet. That was episode 111 and episode 117. So I will link to all of those down below in the show notes. And if you guys enjoyed a conversation like this and you want to have two experts kind of going back and forth like this, please let me know on Instagram. Send me a message at Exam Room Nutrition. I'm sure these two guests would be happy to come on, and I can do any other topics that you'd be interested in. But I would love for my audience to know where they can connect with you and learn from you, because I'm sure they will find so much value from each of your individual contact. So Michelle, where would you like to direct people if they want to hang out with you online?
Yeah, so you can go on my website, entirelynourished.com, and on the top right, you'll see all of my links to Instagram, LinkedIn, all those things. I have an email list with heart disease prevention tips. I have blogs. I have a lot. So just check out my website. That's kind of the hub of where you'll find everything.
And Michelle does an amazing job with her social media. I'm terrible at social media. So if you want a nice, aesthetically pleasing social media, go to her Insta. It's very well done. Mine is like, what's this guy doing? Yeah, good question. So I am on Insta. Terrible at that. You can find me on LinkedIn. But more than anything, I would go to Amazon. And my book, The Home Security System and the Lipid Neighborhood, it's Cholesterol Education Month. It's literally the price of a pumpkin spice latte. And so it's $6.99. I think the royalty I get is like 14 cents or something. So I don't care about that, but I hope that you laugh a little, learn a little, and then come away with a relatable framework for adding some life to your years. And hopefully you read that and get to the end, because there's a message of hope there as well for you. And also it's my dad's birthday. So I want to wish him a happy birthday, because there are very few people in this world that exactly where they stand at all times and are truly awesome people. And he's one of them. So anyway, happy birthday, Dad.
Happy birthday, Dad.
Happy birthday.
Thank you guys so much. Thanks for allowing me to pick your brain. I'm sure my audience will be so grateful for this conversation, and I'm sure we will be having you back on. But thanks again for the gift of your time today.
Thank you.
Thanks for having us.